Good evening, everybody. I hope you're well and welcome to our webinar on continence care. My name is Jan Chaseley and I'm the clinical nurse specialist at Benenden and I am your host for this evening. Our expert presenter is consultant gynecologist, Mr. Abhishek Gupta. The presentation will be followed by a question and answer session. If you'd like to ask a question during or after the presentation, please do so via the Q&A icon, which is on the bottom of your screen. And this can be done without giving your name. If you would like to book a consultation, our friendly private sales advisor, Jane, is available until 8:30 this evening, and we will provide her phone number at the end of the session. Please note that this webinar is being recorded. I'll hand over now to Mr. Abhishek Gupta, and you'll hear from me again shortly. Thank you.
Good evening, everyone. Welcome to our webinar on incontinence, female incontinence. My name is Abhishek Gupta, and I'm a consultant urogynecologist. Why we chose to specialize in this field? More importantly, the whole thinking process in the last couple of decades for urogynecology has changed. Now it's all about quality of life, and the quality of life, it's been more and more clear that how bladder issues can have an impact on a person's life in more than many ways. And everybody's quality of life is differently impacted. So if a person is a kickboxer, they have an incontinence that can affect the profession. If they have small kids, they're running around with the small kids, it can affect their ability to do trampoline with children. If you got a bladder which can't hold urine, you can't go for a drive. So it's all about quality of life. And one of those areas which is well known, but all we see is the tip of iceberg, because obviously as there is a taboo to it, people don't come out and talk it openly. But the treatment and knowing what it's all about can bring the quality of life back to you. And that's what we are focusing here. And it's important for us to recognize this is one of the very common situations and common condition, and it affects a lot of women. So we'll start the presentation. I'll go very slow. And at the end of the day, after the webinar is over, we just want more and more questions so that we can answer the common queries and questions you have, and also gives an insight of how the bladder function works, and also insight of what you can do yourself to help, and what are the treatment of levels. So if things are not getting better by doing simple measures, and when do you need to see us? So as I said, it's what we see here is just a tip of iceberg. It affects almost 35% of women with urine, and that affects around 35% of women. Issues have a leak of urine at some point, and this is what we're talking about, leak. People who don't even have leak, they may have to rush for toilet more often. They have to get up more often, and those problems are not even quantified. So I think at some point this affects roughly around 1 in 2 women. So the quantum, as if you can see, the number of people who get affected with these issues is almost 50%. So it's quite widely prevalent. Now, from a pure incontinence point of view, which is the leak of urine, there are 2 main types. One is urgency of incontinence. So how does one feel what is called urgency? It is when you feel that you really need to rush for toilet, you can't control, or you have to go often. So you go more often, you don't hold that much of urine in the bladder. So when you go to the toilet, you only pass a little amount, but that little amount you find it difficult to hold in the bladder. So you become very uncomfortable very quickly. And that's called urgency. And when you can't avoid the toilet and you leak, it's called urgent continence. Now, typically, when somebody is cooking and they hear a tap going next to them, or you are just parked your car on your driveway, trying to put a key on the lock, and you say, oh, now I need to rush. Oh, no, I need to rush. This is kind of a feedback going on your mind, and that typically is an urge incontinence. So I'm just giving a clue what can incite your feedback. And the bladder is not under control because bladder is doing this. Now, stress incontinence is more defined. It is when you're doing physical work. So that can be when you cough, sneeze, trampoline, anything which increases your tummy pressure, basically. So when you cough, your tummy pressure increases. When you run, your tummy pressure increases. You exercise, sneeze, jump up and down, change of posture. So tummy pressure increases. So what does tummy pressure does? It puts the pressure on your bladder. Bladder is like a balloon filled with water. If you don't have enough of strong support below the bladder, any pressure which increases in your tummy makes you leak. So that's called stress incontinence. Often, the patients present with a mixed picture. And that's not because you have one dominant factor of stress incontinence or urge incontinence in you. If somebody has a quality of life really affected, so for example, somebody is a runner and they go for a long run and they can't hold their bladder because they leak. So what do they do? It's instantaneously, we want to manage our lifestyle. And the way we want to manage our lifestyle is we cut off the events which embarrass us. So what we'll do, we'll try to empty the bladder 10 times so that when we go in a stressful environment or whenever we want to say play tennis or go for a run, our bladder is actually empty. And that becomes a reflex where we continuously trying to empty our bladder so that when we don't leak with stress incontinence. So though we think we have to go more often, but the main problem is stress incontinence because we have trained our mind that we need to keep emptying so that we don't have the embarrassing movement. However, it may coexist together. So you may have stress incontinence and you may have urgency, an urge incontinence together. But it's sometimes the mixed picture is because we have trained ourselves so that we don't have an embarrassing movement. Now, one thing is very important. This is quality of life. And as I said, we still are seeing the tip of iceberg. So I remember when I was training in this field 20 years ago, mainly our cohort of patients were on postmenopausal age group. But more and more, when people know there is help available, people are more open about it. We can see a spectrum of patients who are on a younger age group who this problem is affecting their quality of life, but they were not coming out forward before. So that as the awareness goes, they're coming forward. So for talking about a problem, I think when it starts affecting you, that's the time to seek for help. And this is the first step forward. It's a bold step to talk to doctor or anyone stranger to say that you have a leak of urine. But that's very important for you. If it's affecting you, your confidence, it's affecting your quality of life, it's affecting you doing day-to-day work which you like to do without thinking about an issue with the bladder, then I think that's the time for making the next step. So let's just spend next 2 or 3 minutes just thinking about what causes various kind of incontinence. So as I said, urge incontinence. Urge is your irresistible urge of going for waterworks. That's urge incontinence. If your bladder is full, everybody of us gets the urge to go for it. But this is true urge incontinence happen, or true urgency picture happen when the bladder is only a little full and you reflexly, your bladder is doing this. And then you can't control the bladder and you have to rush for toilet. And that's called overactive bladder because the bladder is overactive. So somebody who, on a normal human being, the bladder can hold around anything between 350 to 500 mL of urine without a problem. For people who have a typically overactive bladder, you go and you can pass only 50 to 150 to 200 mL of urine. So that means you have to go more often, you've got more urgency, and once it's a breaking point, your bladder is doing this, and at 200 mL, you're leaking. Now, obviously, going for waterworks that often is going to be problematic. If you've got a meeting which lasts for 3 hours, you will want to you find it difficult to sit in this meeting for 2.5, 3 hours. But there's some things which we can do to mitigate that risk. If things which really irritate bladder is caffeine, the fizzy drinks. So if you typically have a problem of urgency and frequency, or you have to go in the night, which is called nocturia. So if you get up in the night often, it's called nocturia, which is getting up in the night too often. First and foremost, have a look at how much caffeine intake you've got. If you've got a very high caffeine intake, you won't guarantee to visit toilets more often. It's not a problem. But when it becomes a problem for you, then you really have to think about what coffee and tea intake you have. If you having a higher intake of caffeinated drinks, then try to make them decaffeinated, because caffeine is a powerful irritant of the bladder. Now, a lot of people we talk over the years, they've changed their tea and coffee to more healthier option, or seemingly more healthier option, which is like green tea. But if you look into the label of green tea, it's got a lot of caffeine in it. So if you do want to change it, make sure you go for a decaffeinated option. Similarly, Coke, fizzy drinks are not the best news for the bladder. They irritate the bladder big time. And that can go for, you will have, it doesn't help the situation of overactive bladder. And then obviously excessive amount of alcohol. We all know that when we drink a bit more and sleep, we have to get a few times in the night, and that's what happens. Apart from there, you can have urinary tract infections, and that's more common in a menopausal age group, because bladder is more susceptible for infections once you go into menopause because of lack of hormones or estrogen. And then there can be other neurological factors. If you have a spinal injury, or if you have multiple sclerosis, which is more obvious when they have the issues, which then the bladder is not under your control. Stress incontinence, as I said, is more of when you do an activity, cough, sneeze, jumping up and down, change of posture, running, walking up the stairs, sneezing, and you leak. That's called stress incontinence. And this typically happens because of the weakness of what you define as your pelvic floor, which is the muscles which controls your the whole pelvic floor, which is where it supports the bladder, your womb, and the backside of the vagina. And the neck of the bladder, which is just, so the bladder, if you look, it's a balloon. So if somebody wants to just picture my wrist as a balloon, and that's the urethra, which is tube draining water out. So the neck of the bladder has got what is called sphincter, which is a muscle which contracts and doesn't leak water. So the pelvic floor is supporting here in the vagina, sphincter is inside, and these are the two powerful things which stops you leaking when you cough. What makes them weak? One is vaginal deliveries. We all know we love our children to bits, but they do have a trauma to pelvic floor. So vaginal delivery, especially when somebody has forceps delivery and all that, it does have a big traumatic effect on pelvic floor. So that causes you leak. Obesity. Now, the weight is a factor which again leads to increased chance of stress incontinence. So what is well known is if you got really high weight or you're obese, it causes problems with your knees. We all know that, because the knees can't take your 20 kilos of extra weight every day for many years. But pelvic floor is also bearing the brunt of your excess weight. So obesity is again a big factor for making you susceptible for leaking. Unfortunately, we don't have choice. All of us go older, and when we go older, we have loss of our muscle strength. So we know that our tissues do get weak. And one of the very underreported factor is one of the biggest trauma which a female's body go through. after childbirth is when they attain menopause. Because estrogen, which is a hormone, is so important for the pelvic floor muscles and the vaginal health in the area. And once you have lack of this, it make you susceptible for many things, including weakness of the muscles, including a susceptibility for infection, and therefore a little small hormonal, if obviously you don't have any risk factors, then small hormones in the vaginal area, which is a local treatment, does do wonders and reduces your and also helps to make the pelvic floor and skin condition down below better. Smoking, chronic cough, there's no surprises there. If you're a chronic smoker and you got a bad cough, you'll constantly giving the pressure to your pelvic floor, you'll keep coughing, and that's not going to help with, that will obviously make you increase susceptibility for incontinence. However, that also reduces the chance of success of any intervention you'll go through. So that is something to keep in mind. So if you do like a cigarette or two or more, then if you have a problem with waterworks, if you really want to have a good successful outcome of any surgical intervention or any other intervention, that's the first thing to make your chest better. And as I said, neurological conditions can present with either of that, either overactive bladder or stress incontinence. So it's the nerve-related issues, but they're far and few. So what investigation and how we diagnose things? So when you come to us to say that you have a problem with your waterworks, what will you like to do? So when you come to us, we like to go to ask you to fill up a bladder diary for 48 hours. So what is bladder diary? So bladder diary is something which we ask you to fill to see what you drink, how often you drink, what kind of fluid you drink, and how often you go for waterworks. And we kind of ask you to do a rough measurement of how often you go for waterworks and what amount of urine you drain. So typically, if you got a desk job and you're drinking more than 3 liters of fluid, with half of them is coffee and tea or fizzy drinks, then obviously you will go to waterworks more often. There's nothing wrong with you. If you drink more, you will produce more urine. So there's something very simple to see. However, if you're not drinking that much and you're going often to the toilet and you're only passing 100 or 150 mL of urine, then it's more likely that you got overactive bladder even before we start doing any investigation. So we can start the treatment without you going into any invasive investigation on it. And then we want to see if there is anything causing you leak, either it's with an urge or it's when you cough or you're doing an activity. So there's a bladder diary which we send. So it's an immensely helpful tool for us to initially screen what your condition can be. And that's one of the screening tools which you use and which is non-invasive. Obviously, when you come, we ask you basic questions. We also check if you have any high-risk issues, what your medical problems are, and are you on any medication. Then we always examine you to assess leaking, pelvic floor, any signs of prolapse, and we also rule out that you have any other things in your pelvis. Sometimes a big fibroid, which is a benign growth on your womb, or a big cyst on your ovary can press on your bladder, and that may make you leak. So or if there's a prolapse, which is basically again the weakness of pelvic floor and bladder is coming down or the womb is coming down. So this is all an assessment of prolapse. At the same time, we also judge how your pelvic floor is, because if your pelvic floor is weak, then there is something first line management to build the pelvic floor up, which can be very effective for a mild to moderate issues. And in future as well, if you decide to have a treatment, then any procedure you do, the more success will be if you continue with pelvic floor exercise for the long term, so the recurrence rate is less. And then after this investigation, we make once we have done the basic investigation, we may start your treatment as well, depending on what symptoms you've got. And if these things don't get better, then we usually resort to what is called a urodynamic test. Now, urodynamic test is a functional test to see how your bladder is behaving. So there are 3 components of this test. It takes around 45 minutes to do this procedure. It's a bit of an intrusive test, but the nurses are quite, and Jan and Mary, who does urodynamics here at Benetton, they explain the patients very well. They know exactly what's happening with them. They talk you through the procedure, so they also know what's happening with your bladder. So there are 3 components of this test. One is we ask you to come with relatively full bladder, and then basically what you do is there is a little commode where we ask you to be in. So what we want to see is how quickly you pass urine, i.e. is there any obstruction, or you're not able to empty the bladder, how much you're keeping behind, and how fast you're emptying the bladder. Then we put a little catheter in your bladder, and a small catheter goes in your back passage. We fill up the bladder with water. So what we want to see is the catheter which goes in the bladder is picking up the pressure from the bladder as well as tummy. We're not interested in tummy pressure. We're interested in what your bladder is doing. And hence the catheter from the back passage picks up the tummy pressure. So the 2 pressures so the catheter from the bladder, which is picking the bladder pressure and the tummy pressure, and the catheter from back passage, which is only picking tummy pressure. So we subtract the one from other to just get the bladder pressure. That's what we're interested in. So we fill up the bladder with water, and we see the pressure changes on the bladder. So if somebody has got overactive bladder, then you get the sense of urgency. Oh, I need to go for waterworks. And you tell Jen or Mary who does the test, and they record on the system. At the same time, if you've got typical overactive bladder, we can see the pressure of your bladder going up on the machine. And that's how you diagnose an overactive bladder. If you're too uncomfortable, obviously we'll stop filling. If you can tolerate, we usually like to fill up the bladder with around 350 mils of fluid, which is normal bladder capacity. And then we ask you to cough in between, and we sometimes may ask you to do star jumps. Depends on what your symptoms are. If you leak, it's only water, and that's why you're here. So we can get what's happening so that we can give the treatment you come to seek. Once the urodynamic, and also after the procedure, we also put tap on so that if the bladder gets irritated with the sound of water, which often happens, or put your hands in cold water and see whether that instigate your bladder function and the pressure is recording. After that, we want to see that you're passing urine well, you're emptying the bladder well, and your flow is better, your flow is good. So this is the whole journey, which takes around 45 minutes. And we all ask patients we check that you don't have infection, and we ask patients to drink plenty of water. This usually gives us a diagnosis whether you have overactive bladder, or you have stress incontinence, or you have a mixed picture. And if there is anything which can prevent us offering your treatment, depending on what your bladder capacity is and how you can empty the bladder. So that determines what options of treatment we can give you going forward, depends on the test results. So what are the treatment options? The conservative management. So in an hospital, offering a treatment for the issue of bladder problems, it's my firm belief that the doctors or the consultants can only offer so much. It's the team effort which is needed. So the service is offered as a team. There's no gynecology service or a urogynecology service offered by the consultant ever. This has to be a team effort, because to have any optimal outcome of your problem, you need an input from specialist nurse with physiotherapy input, and the doctors and the consultant in case that doesn't work. So doing conservative management, that's one option. However, if you go for a surgical treatment, the post-operative management, which are mainly done by the nursing colleagues of ours, in any good setup is equally important, if not more. And this is a very important and a basic rule in a treatment of urogynecology. The consultants who are sitting probably with their shiny suits in the clinic are okay to do an operation because we get trained to do an operations. but the real treatment and the value of treatment are provided by the specialist nurse, because that's a total package of treatment. And if you want to have a real optimal outcome, you have to give all the complementary services. And one thing in Benetton is really good is we got 2 specialist nurses, and we are also in a process of recruiting a 3rd one. So we got a complete cohort of services which we offer, and also in line with all the previous recommendations which are happened because of the mesh problems and all that. Every recommendation, like having a multidisciplinary meeting and all that, is been offered at Benetton. So urogyne is or treatment for incontinence prolapse is one of the key services we take pride in providing here. Jan, do you want to talk about this slide about the treatment options for conservative management?
Yeah, absolutely fine. So obviously when you come along to our clinic, we allocate an hour for a new patient, so you get our undivided attention and we can do a whole holistic assessment. But it's basically covering all the things that Mr. Gupta's already mentioned, looking at your bladder diary, what are you drinking, what can we adjust, bladder retraining. So if you're emptying your bladder every hour, to try and get you to empty every hour and 10 minutes and gradually stretch that through so that your bladder capacity increases. You can only really do bladder retraining if we teach you deferment techniques, and that's going to be all around pelvic floor exercises. We'll help you with things like weight loss, advice about smoking. And I think sometimes it's just coming along and just being able to chat about actually what is going on and what can we do for you. There's always the option of medication, but we would never do that as a first line. We would work through the things at the beginning and hope we get an improvement without having to try medication or without potentially having to refer you back to the consultants for surgery. Thank you, Abby.
So as we discussed, so conservative management. So when you come for a bladder issue to us, important thing is you have come here for for improvement. The goal is there's no quick fix. The goal is for a long-term, really good optimal outcome for the problems you have. And therefore, the engagement from you and us both is important to go embark into the journey of making you better. And that's what's important. We need to make you better, and subtle changes will improve. Again, what I'm stressing is it's all about quality of life. It's not the leak which matters. It's about how is that impacting your quality of life and how we can improve that. That is really important message to take from here. Now, we'll talk about medication first, which was on my previous slide. This is mainly for your overactive bladder. So there are 2 kinds of medication for overactive bladder. One is called anticholinergics, which basically what happens is this medication is given to you after you've done the lifestyle medication. It helps to prevent the contraction of the bladder. That's how it works. It takes around 4 weeks to start showing you action. It has got some side effects. And the side effects are usually palpitation, dry mouth, and constipation. The side effects come before the success of the medication kicks in or the effect of medication kicks in. So if you can tolerate the side effects for a week or 2, they're not going to go worse after that. But then you will start finding that this medication started working. The other medication is something called Myrbetriq, which is which is a generic name, which is called Betmega as normal medication known as, which is Myrbetriq, which is the name of the medication that helps to relax the bladder. So they are fundamentally 2 different medications. Myrbetriq has got less side effects, and it helps to relax the bladder more rather than prevents the contraction. Now, this is treatment for overactive bladder. It's not necessarily one medication is better than other. You can start with either of them if you don't have. So if you suffer from severe constipation, for example, there's no point giving anticholinergics. Better to go for Myrbetriq straight away. But if one medication doesn't work, we can start the second medication and see whether it works. Because if that doesn't work and you really have overactive bladder, and people who have a real overactive bladder, their bladders can't hold more than 150, 100, 200 mL of urine if you're lucky. They go often to waterworks, they leak, and that's really affects their quality of life. Then we offer them the next step, which is called bladder Botox injection. It's a very simple procedure to do. It takes roughly around 10 minutes to do. It's not painful. It's done in our ambulatory care unit here. It's basically injection on the bladder wall. It's not painful at all. It takes around a week to 10 days to start acting. And patients who are really got overactive bladder, they feel this is a kind of a life-changing for them. The advantage is, as I said, resistant overactive bladder, which not responded to medication, it responds very well to Botox. The flip side of the Botox is, I won't say the flip side, but it may need repeating. So usually anything between 6 months to 2 years, you will need a top up of Botox on the bladder. And 1 in 12 women, approximately, this relaxes the bladder so much that sometimes you can't empty the bladder well. Therefore, when we give the Botox injection to the bladder, we always empower you to how to catheterize yourself. It sounds more horrible than what it is, but Jan and Mary makes it, it is actually quite an easy procedure. They make sure that you have enough of catheters and you're empowered in case the need arises. It's very simple. It's a small catheter which you can keep in your handbag, and when you need to empty, go to a toilet or very safe in the toilet, and you can empty and use it and throw it in the bin. It throws patients often quite a bit against Botox because of theoretical risk of 1 in 12 needing a catheter. But actually, the catheter, using a catheter after being taught, it's such a simple procedure that once they know what it entails, most of the patients become very confident that this is not a big deal for them. And then comes the nerve stimulation, and there's a little device which goes behind your in your spines, which controls your bladder, which is usually done in a tertiary unit, not done at any normal unit, and not offered Braddon, so it has to be in a specialized London center. Now, for stress incontinence, which is when you leak with cough, sneeze, cough and sneeze, the treatment options have changed remarkably since all of you must have heard about the issues with the mesh. Now, issues with mesh surgery, we all know about. So going back, I think now once you've done your weight loss, you've done pelvic floors, you're still having a problem with stress incontinence, then there are repertoire of options you have. So we have the issues with mesh. Now, therefore, more and more counseling is needed for the patients to understand what they're. Gone are the days when anybody could have offered the treatment or incontinence as a surgery. Now it's only done in the specialist centers with a specialist who do this routinely. In a unit which it should only be done in a unit which has a complete supportive environment, and a unit which is completely urogynecology unit, which has multidisciplinary team meetings, which has got specialist consultants who do this kind of work routinely, and has got specialist nurse and physiotherapists who can advise you with the procedures, the pre-procedure, and the post-procedure issues and successes. So this has now changed dramatically. So we'll talk about stress incontinence in a minute, but for overactive bladder, I think Jan also offers something called PTNS, which is less invasive option. Jan, do you want to talk about PTNS quickly? That's for overactive bladder. Sorry, I jumped the gun a bit.
Yeah, that's fine. So PTNS stands for percutaneous tibial nerve stimulation. So the tibial nerve, which is situated sort of just above your ankle bone, runs up to the base of your spine, and it's responsible also for your bladder. So we offer it privately. It's a 12-week session. It's a tiny little acupuncture needle that just goes in at the side of your ankle, attaches to like a TENS machine, and it gives 30 minutes of stimulation to the tibial nerve. And what you hope that it's going to help with the symptoms of the overactive bladder, the urgency and the frequency. So, I mean, you'd need to be properly assessed by a consultant first to make sure it's an appropriate treatment, but say it is something we offer here.
Thank you, Jen. So when we come to stress incontinence, what are our treatment options are there? So basically, before that, everybody must have heard about the mesh, because every patient I see, the first question they ask, I hope, doctor, you're not doing this horrible mesh, which was paused to be offered in England in 2018 July, which is coming up to almost 3 years now. And this was a TAPE, which was very successful procedure, and still, if you go into NICE, which is gives us advisory capacity, still offers TAPE as a TVT as a treatment option for the patient. It was incredibly successful operation, and the operation itself is not bad. It's a very successful operation as a daycare surgery. The problem happened is, before this time, it was unregulated. So as I was saying, that it was unregulated in the sense, anybody who has a bit of leak, there was no regulation about who can do these tapes and which condition can treat it. So anybody who now going through a surgical option has to be done by the trained consultant who specializes in this field. So gone are the days when general doctors can do these procedures. And the second thing is, each and individual patient has to be discussed in a multidisciplinary team meeting, which has to be two consultants who specialize in the field present, including a specialist nurse or a urologist. They all have to discuss the suitability of this procedure. So anyways, the mesh is on a hold. We don't know whether it will come back or not, but it was a good operation. It had some side effects, I must say, but they were far from few in our practice, and we had a very good success rate. But at the moment, it's on a national pause, and I'm not sure when the pause can be lifted or which hospitals will be allowed to do the tapes in future. So tape itself was not a bad option. It's just we have to assess which patient this mesh is really suitable for. And that's what the problem happened when it was unregulated before. So what are the three other options? So there are two major surgical options. One is what is called Colpo's suspension, which used to be a gold standard operation before 2001, and still sometimes considered gold standard. So what we do on the Colpo's suspension, either done with a keyhole surgery or a little cut in the tummy, which is a bictal line cut. We go deep in the tummy and then put a couple of stitches through the vagina, through the tummy, very close to your bladder, almost in the vagina, and pull this up and stitch with the bone on the back of or near your pubic bone, deep in. Now, this procedure elevates the neck of the bladder, which I was saying. This is the bladder, that's the urethra, which is drains the tube out. So this gives you support here from the top, wakes everything up like this. The advantage of this procedure is none of the procedure are 100% successful. So therefore, I'm saying that we need to optimize the success rate by changing the lifestyles and doing pelvic floors. 75% to 80% patients feel that their quality of life get better with this operation. So if it's around 75-80% success rate, it's a major surgery. It's got a couple of days of hospital stay and about 6 to 8 weeks of recovery period. 1 in 10 women may find it difficult to empty the bladder, may need catheters. It usually settles down with time, and this slightly increases your risk because it gives us such a good support in the front of the vagina. It slightly increases your chance of prolapse on the back of the vagina. That's called post-suspension. The autologous fascial sling is similar to the tape operation or the mesh operation we do, but without the tape. We use your own tissue to make this sling. So what we do, like a picnic cut incision, if somebody had a cesarean section, it's exactly at the same point, just above the pubic bone, we do around a 7 centimeter cut. We harness a tissue from there, which is called rectus sheath. And we go through the vagina, just near the neck of the bladder. We open the vagina there and then put a hammock like this, which goes up and gets stitched again at the tummy. And then we stitch it back. So this is your own tissue as a sling to give you support at the neck of the bladder. This operation, again, has a success rate of around 80%. And the data we have, we are getting that kind of success rate. It's a major surgery. Patient do have to spend a night or two in the hospital. 1 in 10, 1 in 12 patients may need to have catheters, which we may teach you how to catheterize yourself, which usually settles down with time, but can take a few weeks to things to settle down. It doesn't increases your risk of prolapse on the back of the vagina. So that's one advantage over colpoid suspension. And it is quite a successful operation, around 80%. We talk about the tape, so we're not going to talk any more on them. And the last but not the least is something called a bulking agent. Now, bulking agent is a permanent gel, which is called, it's a hydrophilic gel. What hydrophilic means is a 97% made of water, and then other 3% is polyacrylamide. It's an inert gel. So this procedure is done by, we have a look in the bladder with a tube which drains your urine out, which is called urethra. We have a look with the catheter, with the camera to urethra, to the urethra, just at the neck of the bladder. So this is the bladder, that's the urethra, just at the neck of the bladder. So we have a look inside. 4 injections are given. What this does is this gel creates cushions around the neck of the bladder. So gives you support for where the theoretical your sphincter is to reduce your chance of leaking. Now, the advantage of this procedure is it's the least invasive procedure, and more patients can do it. More and more patients are suitable to be done the local anesthetic. And there's no downtime. So you can have the procedure and you can go home and do the normal activity pretty much next day. So that's the least invasive procedure. Use the permanent gel. But at the end of the day, because it's a gel and it doesn't give that kind of support, success rate is quoted as 55 to 60%. In our own audit, which we got an audit, I've got my audit from my NHS practice, we're getting the similar 65 to 70%. We're getting more than 55, 60% results. We're getting approximately 65 to 70% success rate with this procedure. It's a permanent gel, and we may need to do a top-up later on. So once we do it, if it's only partly successful, we do a top-up. Right? The local anesthetic technique has now progressed. So when we initially started the procedure, doing this procedure 3 to 4 years ago, we used to do it in general anesthetic. And then we brought it to outpatient, and we modified our technique from based on the Helsinki technique. We modified and made our own technique. And then the patients do tolerate this procedure very well in outpatients. So the pain score, which is what we measure patients with the pain score, which is visual analog score, which is 0 to 10, how patient perceives the pain. On an average, the pain score for this procedure we're getting is roughly 2 out of 10 or 3 out of 10. So patients are tolerating this procedure very well in outpatients. And therefore, this procedure, we mainly offer this procedure in outpatients. I think both here at Benetton in our ambulatory care unit and also in NHS. And if you are overweight, if you have not finished your family, your fertility is still an issue, but your incontinence affecting quality of life, I would say that rather than going for any major invasive surgery, try this procedure, because at least you've got less invasive procedure. Because if you get pregnant, or if there is a massive loss of weight here and there, then more than likely any surgical procedure will fail, or more likelihood of failure. And the first shot doing any operation is the best shot. So when somebody is unkind to you and said, lose weight or finish your family, it's not they're unkind. They want to give you the best shot, making you better. And we need to have engagement between both of us, patients as the clinician. So on those patients who have not completed their family, or who's got medical problem, health problems, who are not suitable for major operations, or patients who don't want to have any downtime because of other options, then bulking agent becomes a really good option for them. So there is a easy place where you can read about this in which is called NICE Decision Aid, which I've just enumerated. You can Google it up. You can get the NICE Decision Aid. You can read it. And I really like this decision aid because it's written with patient in mind. So it does cut the medical jargons off. It tells you in a language which it's easy to understand to a patient about what this entails, what the success rates are, and what complication rates are, and how we compare this to other. So this is in short from the NICE decision aid, which we have just discussed about. I've explained a bit better with how things work. So that's a short and sweet summary of incontinence and what is available around and to help your condition. And now, Jan, do you want to add anything more, or we'll open it to the floor for questions now?
No, I'm fine. And I've got a few questions. So if you're happy, we'll take some questions.
Yeah, sure.
I think I can probably answer the first one. It says, I'm constantly worried that I'll have an accident when I'm out and about, so I go to the toilet as often as I can. Is this a bad habit to get into? So basically the short answer to that is yes, it is a bad habit to get into. I absolutely understand why you're doing it, because you worry about getting out and about. And being able to, do the things you want to do. But what you're doing is you're getting your bladder to start to think it's not meant to hold very much urine, which is slightly giving you those overactive bladder type symptoms. So to be honest, the best thing to do is, if you've gone to the toilet before you've left home, try not to go to the toilet again to when you get there, or don't go before you leave home and go when you get there. Work on the bladder retraining. If it's something you feel you need help with, please feel free to contact us in the continence care department, and we can help. But try and just work on that bladder retraining so that your bladder capacity doesn't get too small.
And then as if there is a genuine problem that you really can't hold the bladder, and that's, if you know that's not in your head, or you think it's not in your head and it's a genuine problem, then it's no harm getting investigated after you've done the bladder retraining and taken trial of the medication to see whether there's a genuine problem going on, rather than just your habit. So the habit have to be broken. That's what bladder retraining is all about. But if there is a problem and you're trying to hide that problem by just going for waterworks often and making sure your bladder is empty all the time so you don't leak, then we can address the problem itself.
Yeah, and a question for you, Mr. Gupta, although I can't seem to see it, but it was here earlier. It was saying that I'm now postmenopausal and I've noticed I'm getting a slight leak. When should I seek help?
It's actually a very good question, when to seek help. So whether you have a slight leak or you've got a large leak, it's very individual. So depending on what is it affecting you to do, that is the question which only patient can answer. If you've got a slight leak, but this is affecting your confidence, it's affecting you what you love to do, it's affecting you playing golf if you play golf, or it's affecting you to do a kickboxing if you do, or it's affecting you to do trampoline what you do, then you need to seek help. If it's not affecting you and you've got a bit of leak, and then you can always do a pelvic floor exercise or see a nurse specialist to make sure it doesn't get worse in future. But if this affects your quality of life, then you should come forward and see one of us so that we can give you help what's needed. So whether it's a small amount of leak, it's a large amount of leak, when it starts affecting you as an individual, you and your quality of life, because everybody's quality of life is different, then it's time to seek help. If people wear a panty liner and they're not bothered with it, they can manage with pelvic floor exercises. There's no point having any procedures done. But if that is something which is very something which makes you more conscious, makes your confidence go down, make you can't do the activity you love to do, come forward for help. So it's not about quantity of leak, it's when it affects your quality of life.
Yeah, you're absolutely right, because everybody is an individual. So the next question I can answer again is, what is high intake in the terms of caffeine? How many cups of coffee or tea, for example? So what we would generally advise is probably don't really have any more than 2 cups of caffeine in a day, and switch your drinks to decaffeinated. So whatever brand of tea and coffee you have, everybody now makes a decaf version. So buy a decaf version, because then the taste is still going to be the same, and try and just maybe restrict it to 2. And particularly, again, as Mr. Gupta said, look at green teas and some of those other ones. Just check you've got decaffeinated versions. Mr. Gupta, a question that says, can you tell us the names of the medications you mentioned again?
So two medications which I mentioned. One is anticholinergics, which are the commonest one which we prescribe are something called oxybutynin or Vesicare. These are the commonest prescription you will get from your GP or us. Another is called, which is for relaxing the bladder, which is called Mirabegron, which the commonest prescription you get is called Becniga. So these are the 3-4 commonest prescription of medication we give.
Thank you.
And the first medication, which is anticholinergic, which I said has a side effects like dry mouth, also is available in patches. Some people do prefer patches better, which is called Cantara patches, or it's got a medication called oxybutynin. The second one, which has got less side effects, which helps to relax the bladder, is not available on patches.
Thank you. Next question, can stress incontinence be cured by diet and exercise? And if so, how long does it take? So from my perspective, if I'm seeing you and we're going to be working on pelvic floor exercises, and to be honest, the only way you're going to know if you're doing your pelvic floor exercises correctly is to have a proper assessment by either a women's health physiotherapist, by a specialist nurse like myself, so that you're absolutely confident that what you're doing is the right thing to do. And the guidelines say you need at least 3 months of good structured pelvic floor exercises before you're even necessarily going to see any improvement. So the really important thing is to stick with it. Don't get despondent. Hopefully you will get an improvement, but it's not going to be an easy fix. And again, obviously, if you're a little bit overweight, losing weight, it's all about reducing the pressure. So that would help as well.
And it's also a conservative option. If it helps, you will avoid an operation. So that's important. But even when I was trying to tell you about the outcomes of the surgeries, which is 80% success rates or 55 to 60% with the bulking agent, if you are compliant with your exercises and compliant with other health, lifestyle modification, you will be more likely coming in the category of 80%. But if you're non-compliant and you don't say stop smoking, you still have the bad chest, you still are over weight and you get more weight, or you're not going to do your pelvic floor when you get better, in time, you may risk yourself to fall in that 20% category of success. So in any ways, it can improve in the first place and you may avoid seeing me. Or if you do have to see me, you will improve my statistics of success rates because you will be compliant with us.
Why do I need to go to the toilet several times in the morning? Then the rest of the day I'm fine.
Depends on what is the last drink you drink. So if you have an habit of drinking a big glass of water in the night and you get up with a very full bladder, then you may have to take a couple of times to empty the bladder. It's well known when you expand your bladder too much, then you cannot empty the bladder. Nobody can empty the bladder completely in one go. So if the bladder is completely full, you'll take a couple of times to empty the bladder. Second thing is worth looking at if you got any swelling on your leg, because some people have something called lymphedema, which is the swelling of your legs. And that's what happens when you sleep. All this fluid, which is when you're awake and you're walking around, the gravity is soaking that fluid in your legs. It comes in your bloodstream and you produce more urine. Therefore, you get up with a very full bladder, has to do a few times. And the third thing which can also happen is see what medication you have. And if you are on a medication like a diuretic, which makes you produce more urine, what timing of medication you take. So these are the kind of lifestyle changes. If these are all taken care and you still have to pass 2 or 3 times in the morning before you're fine, then probably you might have to see Jan before doing anything, because it may be just a lifestyle adjustment you need.
Lovely, thank you. And thank you very much. I'm sorry if we didn't get round to answering all of your questions, and we will do so after the event. If you'd like to book a consultation, either with us as a specialist nurses or with Mr. Gupta, the private patient sales advisor, Jane, is available tonight until 8:30 on the number that's showing on your screen. You will receive a short survey, and I would be grateful if you could spare a few minutes to let us have your feedback on today's webinar. Our next webinar is on Wednesday, the 10th of November, with Mr. Steve Garnett, consultant urologist, and he'll be discussing Urolift, which is a minimally invasive treatment for enlarged prostates. So on behalf of Mr. Abhishek Gupta, myself and all the team at Benetton, I'd like to say thank you very much for joining us today, and we look forward to you joining us again for another webinar very soon. Thank you. Bye-bye.